Welcome everyone, my name is Michael McCall and I'm one of the founders of the Emergency Care Research and Development Special Interest Group. I would just like to tell you a bit more about the group. This group aims to support, promote and develop emergency medical care research in South Africa. And that's right about all that I'm going to say at the moment, because I know you'd want to listen to this Prezi and our online hangout. Just to let you know that you should please email us if you have any questions or suggestions or would like to join the SIG, either in your own academic endeavors as a student or a postgrad student. We'd love to hear from you, as we've got a vast majority of experience in research from a team of biostatisticians, epidemiologists and clinicians in emergency medical care. The SIG is also supported by the Center for Evidence-Based Healthcare at Stellenbosch University, so please do get in touch with us. The email at the bottom of our logo there, you're welcome to email that and get hold of us. Otherwise, that's from my side, Michael McCall, and I would like to hand over to Ben Duval, a lecturer at CPUT, on an exciting Hangout lecture that we did live.
All right, evening everyone. I'd like to start out by just thanking Michael and Willem for inviting me to do this session. All right, so what we're going to look at this evening is just a presentation on some theory and discussion around clinical research methods as applied to emergency care. So, as you all know, or for those of you who don't, I'm a lecturer in the Department of Emergency Medical Science at CPUT. My name is Ben Duval. And a little bit of short history from me. I've been involved in research in emergency care for quite some time. I've supervised a number of projects in emergency care, and I've also done some work in clinical epidemiology. In terms of the outcomes for this short presentation, really at the end you should be able to have a little bit of a better understanding around what research paradigms are all about. You should be able to describe basically the difference between, in clinical research at least, what observational studies and experimental studies aim to do, and then look, basically be able to describe some of the conventional study designs that we would use in clinical research, and also describe some of the factors which may influence the validity of those findings. So essentially that will hopefully enable you to, if you're interested in doing research of this nature, it might help you in designing studies. And it could also improve your research literacy. So when you're reading clinical research particularly, it might help you to be able to appraise some of the work that you're reading with a little bit more skill. All right, so firstly we'll start off by looking at what is research. Now, research is generally defined as a very systematic inquiry into nature and society to either refine existing knowledge or generate new knowledge. Just to pause here for a second, the scope of this particular presentation is going to focus more on clinical research. So we'll be looking into an inquiry into nature, not really the societal aspects of research, which is not always the focus of clinical research particularly. Right. To move along. In terms of paradigms, this is something that I found in teaching research classes that students often seem to confuse. Now obviously the philosophy of research is a little bit too detailed and complex for this session itself. However, I thought it was important just to outline the differences between the two. So the two paradigms that exist in research really is the qualitative paradigm and then the quantitative paradigm. So how do they differ? Well, in essence, the qualitative paradigm really looks at studying phenomenon, where quantitative research is used to study things by measuring and counting, very much a positivistic philosophical positioning. How are they used? Well, usually in social science research, sometimes in educational research, qualitative research enables us to look at particular problems that relate to phenomenon and how people learn, and it essentially allows us to examine multiple aspects of a problem through multiple different lenses or multiple realities. When quantitative research, we're really just interested in quantifying it and looking at particularly things such as exposures and or relationships. And so in terms of when they use, clinical research tends to focus or use mostly methodologies that link to the quantitative paradigm, while social sciences looks more at qualitative research. Now, it's important at this junction to just say that both of these research paradigms have a place in emergency care research. However, in the clinical aspect, the predominant demarcation really is quantitative research, and that's where our focus will lie tonight, looking at the epidemiological approach, particularly to study design. All right, so I thought that it would be important, seeing that I'm not quite sure exactly who is all listening to this broadcast, to just look at some basic concepts of epidemiology to ensure that we all have the same baseline to look at some of these studies designs later. So we'll start off just by looking at some fundamental concepts in epidemiology, and then looking at sampling and why sampling is so important. So the first concept that we want to look at is the concept of causation. This is particularly important in clinical research. Association does not necessarily apply or imply causation itself. This is very important in clinical research because very often we'd observe an association and see, oh, well, this exposure relates to that disease, or this drug may improve somebody's blood pressure, but that's a dangerous assumption to make if we cannot prove causation. So for an exposure or anything to be considered a cause, there really needs to be a strong, reproducible, and predictable relationship between the exposure and the development of a disease as compared to the risk of developing that disease without the presence of the exposure being present. And then we also have to just consider the different types of causes. And here in epidemiology, we really look at necessary, sufficient, and component causes. And pulmonary TB is a nice example to explain this. If you consider a patient with TB, a necessary cause for TB would be an infection with Mycobacterium tuberculosis. Without the bacteria being present, you generally wouldn't have TB. However, most of us carry TB, and TB is quite common. It's a common pathogen, and most of us would come into contact with it quite regularly, but we don't all develop tuberculosis per se. So the next component cause then would also, for example, be your living conditions and what your degree of exposure is, how many people around you have TB. And if you put those component causes, the individual factors into one mix, you may develop what's referred to as sufficient cause. So actually a sufficient cause to develop that disease. And this is very important because very often in clinical research, we look at only components. You must not forget that you need multiple factors often to coincide for something to actually happen. The next slide, I think, is particularly important because most research really aims at finding the truth. And in clinical and quantitative research, we really consider three big spheres that can skew us or that can influence a study's ability to find the truth. The first one over here in the middle, this one that I'm going to, the green one, refers to random error. Now, random error, or another way to put it, measurement error, is where for some reason, just by chance, when we take a measurement, for example, a blood pressure or hemoglucose test, just by chance, the measurement is slightly off. It's not quite correct through a factor that we couldn't predict or foresee. And it's different almost every time. And the degree to which random error occurs can really dilute a study's ability to find the truth. The next important factor is that of confounding. Now here we have something that creates what appears to be an association, but when we interrogate further, we find that this has actually skewed our view. And I'll speak about confounding a little bit more in the next slide to explain it better. The next would be bias. Now bias can, and there are many types of biases. Once again, I'll go to another slide in a minute. Bias is particularly important because it creates a systematic skew, or systematic type of skewing of your view. So if you, for example, and a great example is selection bias, if we were doing a study to see whether a drug improved a patient's risk or decreased the patient's risk rather of cardiovascular disease, but we only picked patients in which the drug was highly likely to work, then we may have introduced a selection bias. So the study might find that the drug works very well, but when it's applied to the real world patient, who might not be the best patient, who might suffer adverse effects, then we realize that that systematic bias is in fact skewed the study, and the drug was, and we didn't actually find that true effect. Right, so let's move on to look at confounding. Now, this is a great example to describe confounding. A few years ago, a large cohort study was done into exposures and risk factors for heart disease. And one of the exposures that came up with quite a significant association to heart disease with coffee drinking. It was most certainly not good news for most emergency care providers, as I think we consume quite a bit of coffee. However, this is quite striking because if one considers coffee drinking, there should be no reason why coffee or caffeine maybe in the coffee should be causing heart disease. Well, when the investigators looked a bit further, they found that very often the social behavior that went with coffee drinking was using tobacco. And between tobacco use and heart disease, there is a very clear, true association with disease. And so in this case, this example, coffee drinking represents a confounder, where there appears to be an association between a risk factor and a disease, but in fact, that association is not really there. So to be a confounder, that confounding variable, in this case coffee drinking, must be an independent risk factor. It must be associated with the exposure, and a confounder cannot itself be caused by the exposure. So this is a very important concept to consider, because very often when we look at clinical research, these confounders may be present. We think, for example, at neurological outcome in a study that evaluates, for example, rapid sequence intubation against patients who are not intubated. The degree of injury or injury severity may be a significant confounder, for example. If the patients between the two groups are not comparable, then it would be possible that more severe patients may have worse outcomes just because they do, and that could represent a confounding variable, for example. The next slide here now looks at bias. Now, I've listed various biases. I'm not going to discuss each of them individually, but essentially a bias is a systematic error. And we've already touched on selection bias, but I think volunteer bias is quite a nice one to look at as well. Sometimes this can be referred to as the healthy worker effect, for example, as well in the workplace. Now, when you sample and you use volunteers have certain characteristics. And for example, if your study wanted to look at elements of motivation, for instance, volunteers might be a very bad population to look at because they are motivated to volunteer. And that may introduce a certain degree of bias in your study, depending on the questions you ask. Another important one is loss to follow-up. Very often in clinical studies, patients tend to disappear and we can't find them again. And if we can't find all the patients we gave the experimental treatments to, then that could pose a significant problem where, for example, a treatment may appear better than it actually is simply because the patients that we couldn't find had died and we couldn't locate them, or they had such adverse effects that they didn't want to come back for follow-up treatments or visits. All right, so let's move on to the next one. The next concept that's important to look at is the concept of validity of a study. And very often there's two terms that are referred to, internal validity and external validity. But just quickly, internal validity really asks the question around, does the study measure what it intends to measure? So if a study, for example, wanted to look at the effect of a medication on a patient's blood pressure, one would have to ask, well, how accurate was the blood pressure measurements that were taken? Were they done with arterial blood pressure monitoring or just with a cuff? Was there a procedure? Was that procedure standardized, etc., etc.? Because if it wasn't, then so many of the measurements may in fact have been false, and that could affect the study's ability to tell whether or not that medication had actually worked. It might be due to measurement error. External validity, on the other hand, really speaks to whether or not the results can be extrapolated to the population. This is very much to do with sampling and the way that it was, and the way that the sampling for the study was conducted. We'll deal with sampling a little bit more in a little bit. But what's important here is that if the sample in a study is not representative of the population, then one can't really take the results and apply it to the population in general. And this is a particular problem for EMS research and much of the research that we use in South Africa. If you consider that a lot of the research is done in other countries, there may be problems with applying findings of such research in South Africa to our particular population, just as an example. All right, so linked to the idea of validity is also the concepts of precision and accuracy. Here we have a graphical representation. So obviously the best place to have a study is in this quadrant over here. If you look there, here we have high reliability, so the study is reproducible, and every time we do it, we find the same result. And we also have high validity. So if we looked at measurements, and let's just say these were blood pressure measurements after giving a patient a drug that lowered blood pressure, we'd obviously want the measurements to correlate very closely with what the true value actually is. And what you notice as well here is that the measurements are quite close together, which means that there is some variation, but not much. So we know that the study is quite accurate in finding what it tends to find. However, if we go down here, we'll see that the measurements are really all over the place. So when we look at data from a study like this, we really actually can't tell whether or not that medication has had an effect. In this case, for example, the measurements are quite close together, but they're nowhere near the truth. And here, a systematic bias may in fact have skewed our results. All right, so let's move on to the next slide. So now we're going to look at the importance of sampling. Now, sampling is quite a big topic on its own, but we'll just do some very basic, let's talk about some very basic concepts quickly. Just firstly, the difference between a population and a sample. A sample is what we draw from a population. And we do this for a simple reason. It's very difficult to study an entire population. Very costly, they're quite big, and time is obviously always against us. So we sample from a population in order to be able to conduct studies. But this is a very difficult process, because if we wanted to infer our study results back to the population, we really need to draw a sample that is representative. And this may sound much more difficult than it is, or it is a lot more difficult than it sounds, rather. So one of the things that allows us to use samples is the fact that we can calculate statistics, and that's really what statistics are. It's sample measurements, or measurements within a sample, that we then calculate statistics around and do statistical tests around to be able to extrapolate and infer back to the population. And that's really what statistics are all about. But now, if you consider, for example, a mean value, if we wanted to know what the average blood pressure is for patients in the Western Cape, if we sampled only people from one suburb in the Western Cape, and we took them consecutively, so we literally went door to door, that would not be very random. And in fact, we may have just by chance picked a very affluent suburb where people took after themselves. If we take the data from that study, we may find, for instance, that the blood pressure values seem normal. And we could then conclude that people in the Western Cape have generally normal blood pressures, but that would be a very false result. The statistics would show that the mean blood pressure or the average blood pressure is low, but because the sample wasn't taken from the population which we're now inferring it to, that's actually a false result, and we would be incorrect in making that or coming to that conclusion. So sampling statistics go together, and and therefore it's very important to have a bit of an understanding around what statistics are about and how to interpret them, because it can be very dangerous to interpret them without sufficient knowledge. Now, in terms of dealing with statistics, this session is not geared towards that, so we're not going to do that, but I think maybe at a later stage that is something that Michael and Willem can consider doing, just looking at a little bit of statistics literacy to explain what all these big numbers and p-values and tests actually mean. Now, the next concept that I want to deal with that I've already mentioned is random samples, or sampling random. Now, this is very important because if we sampled and chose people to participate in our study, there will always be some degree of bias, even if we don't intend it. We mentioned earlier volunteer bias. We mentioned specific sampling biases, where we pick people who may do better in our study or give us the results we want. For this reason, if we wanted to infer back to a population, we need to take samples, or we need to select participants from that population who represent it. So we need to do this in a random way, basically to allow or to make sure that that everybody in the population had the same chance to be in the study at the beginning when we started sampling, ensuring that that sample represents the population in general when we now want to infer back to that population. Right, so in terms of the hierarchy of evidence in medicine, this is now the type of study designs which are considered, or how they're considered in terms of where they rank, at which level they provide the best evidence. So you'll see that you'll see a lot of these names. You might not recognize all of them yet, but we'll deal with many of them a little bit later in the lecture. You'll see that in vitro test tube research, basic science research, ranks right at the bottom. Basically because it's not applied. So in clinical medicine, we can't use results from that. We can't say that because adrenaline has shown to work well in animals in cardiac arrest, that we can simply just use it in humans. That's a bit of a leap too far. So animal research and test tube research is where most ideas begin. Above that, you'll see that editorials and opinions start to appear. And this is very important because people are often influenced by opinions of more senior people in the profession, or editorials or ideas that float around. And we see this particularly in EMS quite a lot. In practice, certain people hold a great deal of influence over how people perform, and this may even be as a result of certain standardized practices and so forth, or just culture, the way that EMS has developed over the years. And I think this is very important to see this, because in terms of evidence, that doesn't necessarily mean that we're doing the right thing. Above that, we can see that we have case reports or case series, where we now look at individual cases. So, for example, we find an interesting case of a patient who presented with signs of a stroke, but in fact he was hypoglycemic, and we can report that as a case, because practitioners might find it interesting, but those can be isolated. They're not necessarily presenting good evidence. It doesn't imply that every patient presenting with stroke symptoms should necessarily be screened for other strange causes that might in fact just be a stroke. Then we can see that above that, we start getting where we're now looking at what's called observational analytical studies, studies that specifically test associations like cohort and case control studies. And then towards the top, we start getting our randomized control trials, which we usually use to test particularly interventions. We want to see whether one intervention works better than the other. And then right at the top, we get systematic reviews and meta-analysis, where we actually take randomized control trials themselves, pull the results together, and then look at a much bigger picture with a much bigger sample. And these types of study designs tend to give us the best kind of clinical evidence because they've also gone through multiple layers of critique. They usually have risk of bias assessments, for example, included, which really allows us to, which really, when they're published, they're rather refined documents with a very good basis for making conclusions or drawing conclusions from. So what we're going to do now is we're going to start looking more towards some of these designs. But before we get there, in other words, to summarize what we've gone so far, or what we've done so far, designs which reduce bias, reduce confounding, and reduce random error, increase internal and external validity, are representative of the study population that we wish to talk about or infer to at the end, are considered to be the robust type of study design and provide high level and high quality evidence, which we can then actually start using and implementing in clinical practice. And this is a very, very important point where I want to pause for a moment. If we think about emergency care and emergency care research, there really is a paucity of this type of research. We borrow a great deal of what we do from other health professions, cardiology, anesthetics, and emergency medicine, for instance. And there's not necessarily a great deal of research that has actually been done in the pre-hospital setting that has high quality. And this is, I think, in large part the aim of this presentation this evening, is to introduce people and try and motivate and inspire people to do this kind of research, because this is what we need if we really are going to start improving our practice. All right, so let's look at some of the actual study designs. Now, broadly, epidemiological or clinical study designs can be divided into two broad groups: observational and experimental. So let's start off by looking at the observational group. In observational study designs, there are once again two divisions: analytical designs and descriptive design. Now, analytical designs look at quantifying relationships. That's what they're all about. They want to see whether or not there is a relationship, what the strength of that relationship is, and the direction. Does an exposure increase risk, or does a treatment decrease risk, etc. And then descriptive designs look at describing the status quo, what is happening now, essentially just giving us snapshots of what's going on in practice. So let's go ahead and look at analytical designs themselves. Now, the first analytical design we can look at is the cohort study design. In simple terms, what this study design does is that we're wanting to see whether or not there's a relationship between a certain exposure, whatever that exposure may be, and the incidence or the outcome of the risk of developing a disease when the exposure is present as opposed to the exposure not being present. The way these studies work is that they tend to run forward in time, and the direction of inquiry is also forward in time. So we find a population, we sample people from that population who do not have the disease of interest or whatever it is that we're looking for. We look at those who have the exposure that we're interested in, for example, living in a house that has many TB contacts as opposed to people who do not. And then we look at how many people develop the disease forward in time now, so we follow them up maybe a few months or even years later, and see how many people have actually developed the disease in the group that was exposed as compared to those who did not. And we repeat the same measure in the group that wasn't exposed. So how many people in the group who wasn't exposed developed the disease as opposed to those who did not. Now, that sounds quite difficult, and it is rather. This is one of the more complicated designs. But you can use not only prospective data, as I explain it now, you can use retrospective data as well. So just to clarify, not to confuse anyone, the direction of inquiry is always forward. So we always look from the time where people didn't have the disease to where they did develop the disease. But we can take data that was collected some time ago to do that. And that would be what's referred to as retrospective data, as opposed to prospective data, where we collect the data from today actually going on. So this is generally used, these designs are generally used to study people who share certain characteristics, such as those who are smokers, or those, for example, who've been transported by ambulances for asthma, or how many ambulance transports they have for asthma, for example, used to describe the incidence and the outcome in a group of very similar people. In terms of study design itself, it tends to be good for calculating risk and risk reduction. So we can say what the reduction in risk is if we put an intervention in place, or if the exposure is not present, for example, smoking and the risk of lung cancer. The great advantage of this kind of design is that you can actually look at multiple outcomes at the same time. And this is a great strength of this type of study design, where we can really see, well, what is the effect of, for example, ambulance transport on outcomes in, let's say, for instance, maternity patients who have complications in a rural setting, and we can look at multiple outcomes: the outcome of the mother, the outcome of the baby, etc. It's also a good method for rarer exposures, things that are maybe not common. And so, although it seems like a difficult study design to do, it might be well suited to some types of emergency care study, and I'll cover some examples of that again later. The big problem with this type of study design is that it is time consuming, it is costly. Very often you will need funding for this, and you need well designed and usually large samples. Often lost to follow-up, and finding patients later can be a problem, and as well as confounding. And as we mentioned earlier, because you're looking at many variables and you might not consider all of them at the outset, confounding can possibly skew your result because you might be caught looking for associations that in fact do not exist. So this is a danger in the study, and you would need guidance to help you make sure that you don't fall victim to the confounding, as we illustrated in our coffee drinking example earlier. All right, so let's move on to the next design. The next one is called a case control study. Now, it's very similar to a cohort study in some ways, in that it also looks at the an association, once again, between an exposure and a development of the disease. However, it does it in a slightly different way. So now, once again, if you look at the top here, you can see that time moves forward, but the direction of inquiry moves backwards. So instead of finding people who are not diseased, we do the opposite. We find people who are cases, who are known with the disease. We then find and identify people who are similar than the cases, other than for having the disease. We call them the controls. And we ask them and look backwards in time to what their exposures were. So what were they exposed to? What were the cases exposed to? What were the controls exposed to? And then we can look at the associations between, in cases, for example, between those who are cases and were exposed and not exposed, and those who are controls who were exposed and not exposed. And once again, this can tell us about risk in relation to exposure. Once again, we can look at multiple exposures using this type of study design. And the one advantage is that smaller samples than cohort studies can be used, because other than in cohort studies where we're waiting for people to develop the disease or to have an injury, etc., in these cases, we've actually identified those individuals and we've merely matched them with controls. Now, in terms of this study design, it's generally good for looking at associations, and it is less time consuming usually than cohort study. Because you have smaller samples and it can be quicker to do, it may also be less expensive than cohort study. It may be good for rarer diseases or rarer situations. Again, we can, like I said earlier, look at multiple exposures. The difficulties with the study is really in selecting good cases and then selecting good controls. Controls can be very hard to identify, because what would be important to ensure that no confounding into the study is that the controls and the cases would need to be very, very similar, other than for whatever exposure it is that you were looking for. So they may need to be similar in age. For example, looking at trauma, they may have similar starting neurological symptoms or similar injury severity scores, etc., etc. Otherwise, it would be easy for there to be a selection bias, or, for example, for confounding to be a problem. Another big issue with case control studies is that of recall bias, and that refers to a type of information bias where patients essentially may remember things differently or may report things incorrectly, particularly over-reporting symptoms can be an example. Or if we look at EMS situations, for example, where we might be looking retrospectively at PRFs or patient report forms, where patient report forms are not maybe documented correctly, or there's problems in the information that they contain, that may be a particular problem. It's not that good for very rare exposures, but although it can be good for rare diseases, because remember, other than cohort studies, we now look at it from the other perspective. And the only statistic that can be calculated here is an odds ratio, and odds ratios are not as sensitive as some of the other statistics we can calculate when we use cohort study. Although I won't go into that too much detail for this presentation. Let's move on to the next one. The next one we want to look at is a cross-sectional study design. Now, cross-sectional design really just give us a snapshot of the present. So instead of looking forward in time or looking back in time, evaluating exposure of disease, we just collect data and we see whether or not there's an association in our snapshot in our very short time period in which we collect the sample between an exposure and a disease or an outcome versus patients who don't have the exposure and disease of outcome, as compared to being exposed without the disease and there being no exposure without without the disease. So it essentially can give us a ratio, give us a little bit of information about whether or not something may be associated with an exposure. These are generally good for the fact that they're easy and they're cheap, they're quick to perform. They can look at prevalence. Very often these type of studies are the first step. They're good pilot studies to tell us whether or not we may want to do a more complicated study like the case control study or a cohort study. They tend to have fewer ethical issues associated because we're not going to watch patients getting ill and observe them. It's a very quick snapshot, and we may want to make decisions on the basis of that, and they can be comparative. The drawbacks is that temporality of disease and disease timing, or how disease occurs, can, for example, be a problem. So depending on how long our sample period is, we may not be able to follow up how many of the patients that were exposed but didn't have our outcome of interest yet actually developed that later. It is easy to overstate findings for that reason in this type of study particularly. Often dead patients or patients who die later are excluded, and for that reason it's easy to see associations that don't exist. All right, so just one thing I want to mention about cross-sectional studies as well. The cross-sectional studies can be analytical, but they may also be descriptive only, and I think we'll go to the descriptive studies now. All right, so descriptive studies, as we mentioned earlier, really about describing status quo. Let's move on to that. The first one is a descriptive survey. It's really just a summary of routine data, so things that we would be collecting normally. So what is the response time? What is the distribution of calls? Those sorts of things. It's interested in quantifying the frequency of an observation, such as the number of asthma cases or the number of severe asthma cases over a time period. Because it's only descriptive and it doesn't look or have any analytical component, it cannot really quantify relationships and only really tell us about what is happening on the ground. Now, my observation over the last few years have been being involved with particularly BTech research and getting some insight into some master's research in emergency care in South Africa. A lot of research is focusing around being descriptive, especially if it is quantitative. Now, this is not necessarily a critique because it's not a bad place to start as a researcher. It's a simple study to do. It's not very complex. It doesn't have many ethical issues. However, this kind of data will not really advance our clinical practice. However, it will do a lot in giving us more insight into what happens in our systems. And so, although this research is a good type of design to start off with, and definitely necessary, we do need to also start looking at more analytical research to tell us more about what we're doing in clinical practice. All right, the next one is a case study design, which really looks at a single case. So it's very simple description of a single case. It can be useful to describe a number or situations of rare cases. So, for example, where something interesting has happened in a call. Case series is a number of cases with a certain common theme. So, for example, cases where needle decompression has failed, and we can document those, and we can, for example, see whether or not there were common themes, which can also help us design better, bigger studies. Right, so now let's move on to the experimental way. Now, experimental designs, in principle, are distinguished by the fact that an intervention is now being provided as opposed to the research just observing, as we've seen in the previous study design. In terms of the two types of experimental studies, we really have randomized control trials and then non-randomized control trials. Now, randomized control trial is actually quite simple. It's not that complex. It's a random allocation of an intervention. The researcher attempts for lack of a better term, to modify a disease course by just changing a determinant, like an exposure of treatment. So the way that it works is quite simple. At the beginning of a study, we have subjects that we want to study. They meet our entrance criteria. We randomly allocate them into two groups. So purely by chance, they either end up in the experimental group or the control group, and then the experimental group usually gets our treatment or our intervention. We then observe their outcome, and the control group don't get an intervention. They get often a placebo, for example, in pharmaceutical trials, and we observe their outcome. And then we see whether or not the experimental group subjects are better. Now, what's particularly important in randomized control trials is the concept of randomization. To explain it simply, it's to allow each participant an equal chance at the beginning of the study to receive either the treatment or the placebo. So this is important because it distributes the baseline characteristics within the group equally. So people, because it's randomized, similar levels of random error or even confounding is just distributed between the groups so that the groups remain comparable. It in itself can reduce the incidence of random error or the effect that random error can have on the study. Like I said earlier, it also distributes confounding variables equally between two groups. And because it's now randomized, it can reduce the risk of selection bias, where we don't really pick people who would do better in the experimental group. The next important factor is that of blinding. Now, blinding can refer to a few different people being blinded. And blinding is essentially that a participant, either a patient or a practitioner or even the researchers, are blinded to the allocation of the treatment in the study. So what would usually happen is that, for example, in clinical trials where drugs are tested and the placebo is used, the placebo would very often be used and look exactly the same as the treatment. And for that reason, patients and practitioners can't really tell which medication the patient is receiving. And often you'll read that a study can be single, double, or triple blinded. Simply refer to single, usually the patient, double, the patient and the treating clinicians, and triple blinded, often the researchers as well, where only later on do they realize which patients were allocated. And this refers to the allocation concealment, which I described briefly earlier. Okay, so the big, I won't go through all of this, but the big strengths of randomized control trials, they provide really, really robust, they're considered the best type of designs for interventions. They control confounding and bias, and they can establish a causal relationship between being exposed to the intervention and the outcome, and then we can calculate the risk difference. We won't go through all the limitations, but I think when this lecture is available later on, people can just read them for themselves. All right, now in non-randomized trials, I won't spend much time on this. It's very simple. Essentially, there is no randomization, usually no control group. So these studies usually take the form of before-after studies or crossover trials, and they're very vulnerable to confounding and bias. So most people would generally say that if you're going to do a type of experimental design, you should really aim to do a randomized control trial, as it won't introduce unnecessary bias into your study. Right, so let's just move on quickly. We'll just deal very briefly with systematic reviews. Now, a systematic review, I think, is particularly important for EMS because we can use data from other researchers and from other parts of the world to give us more robust results or evidence around clinical intervention. So there's a couple of different definitions, but the one I selected, I think, is the easiest for me. It's a review in which bias has been reduced by systematic identification, appraisal, synthesis, and even statistical tests of all the relevant studies on a specific topic according to a predetermined explicit method. So I think what's very important just to differentiate this from a literature review. In the literature review, we would usually go and we would search, and very often students will go, first place they'll go is Google, and then maybe The lecturer is lucky, they'll go to Google Scholar and they'll type in a couple of keywords and they'll find some studies. And very often they'll exclude the studies that don't support their argument, and they'll just take the ones that they can reference that say that what they want to say. And that's called cherry picking, and it's rather dangerous because it is in itself, it's a selection bias, and you're selecting only what you want. Now, in a systematic review, the objective is not to cherry pick and present a certain argument. The objective is to find out whether or not a certain intervention will actually be better than other interventions. So if we look quickly at systematic reviews, it's the hallmarks of a systematic review that sets it apart from a normal literature review is that it's got a very well delineated specific question, very much like a research question. It is actually in itself a research design. Its secondary research might not be empirical, but it is still following the same kind of systematic inquiry. So very well delineated specific question. It's structured. It's comprehensive. So the search strategy is very comprehensive. We would search all the major databases and even sometimes the grey literature, unpublished works. It's a reproducible search strategy, so the authors usually publish the search strategy so that people can go and see how they found their results. It has a well-defined inclusion criteria, so studies are included that are compatible, and studies that are not compatible or didn't look at the same outcomes or didn't have the same types of methods usually not included, so that the results can be synthesized for similar types of studies with similar types of patients. Risk of bias assessments are performed where the authors would look, for example, at who did the study, how it was funded, whether or not the study concludes what it found. Multiple reviewers are often used where there would need to be agreement between reviewers, and because of the nature of systematic reviews, they prefer usually randomized control trials because these provide the highest level of evidence, although it's not impossible to do systematic reviews of non-randomized trials. Now, very often systematic reviews include something called a meta-analysis. Now, this is a complex statistical process, which I don't want to go into too much depth with, because I think Michael might actually be able to give us a better explanation of it. But essentially, what a meta-analysis does is it takes all the data for a point estimate. So, for example, an odds ratio. So, in this case, if we look at our little graph here, is pre-hospital fibrinolysis better than in-hospital fibrinolysis? And essentially, it pulls all these odds ratios and all the patients together and says, well, if we said that all of these studies were comparable and all of them had individual numbers of patients, you can see it 100, 166. If we put all of these patients together and we recalculated the odds ratios, considering that we've already assessed them for bias, etc., then we can come up with a point estimate that includes all of these studies. So now, instead of having a study with only 311 patients, we actually have a bigger value of 6,400 patients, which is a much larger sample. So when we conclude our results, you can see that these little bars here on the side represent the variability. There's a lot less variability around that point estimate. It means that it's a much more accurate measure, and we can make a much clearer determination of whether or not thrombolysis would be better pre-hospital or in-hospital on that basis, for example. Right. So this is a very useful statistic, although there are many assumptions in a systematic review that we need to be met before this can actually be performed. Okay. All right, so what I decided to do next is give some basic examples, because I think that what we've done in the last half an hour or so might be a bit of information overload. So let's just reorientate ourselves and put this into practice a little bit. So let's look at some examples that can be applied to the emergency care setting. Now I'm going to present some problems and then potential study designs that may be possible. However, these problems can be studied with different designs. I've kind of just selected them for ease of understanding. So I hope you can follow me on this one. Right, so let's look at the first example. Here's a problem. In this community that we saw just now, a large number of people experience ACS annually. Now, the EMS system is considering implementing pre-hospital fibrinolysis as the nearest PCI facility the nearest hospital with a cardiology unit is more than 90 minutes away. So if you are familiar with the international recommendations, that's where pre-hospital fibrinolysis may be useful. But the question they have is, well, are there enough patients who will actually meet the eligibility criteria for fibrinolysis? Because as you know, fibrinolytic drugs can be rather expensive to buy. And the MS is a little bit worried about having these drugs sitting around and actually not being used. So the investigators in this kind of scenario, they wanted to know whether or not there would be enough patients or whether there is a sufficient or a significant need. Investigators could use a cross-sectional study design where they could look at the prevalence of STEMI and then compare it to the frequency of patients with STEMI who would meet the pre-hospital inclusion criteria for fibrinolysis, as an example. And here is a paper published a little while ago in 2006, where they actually did exactly that. They looked at basically a descriptive analysis, so retrospective. They used some retrospective data, but they did a cross-sectional study, and they looked at how many of those patients would meet the criteria and actually be able to receive fibrinolysis in that area. So a really nice example of how we could potentially do research of this nature. Right, so let's move on to another problem. So in this setting, as you can see, now dealing with trauma. In the rural setting, motor vehicle collisions are associated to high mortality rates due to bleeding and traumatic brain injury. Now, the investigators are interested here in studying whether the use of hypertonic saline, for example, would improve patient outcomes as compared to standard treatment. So obviously, they're thinking, well, in fluid resuscitation, hypertonic saline has been shown that may be useful, and the question of traumatic brain injury remains: is it safe, and would it not cause harm, and would it also be sufficient in terms of resuscitating the patient? So here the investigators could use a randomized control trial. They could make the inclusion criteria quite tight for a very specific subset of patients. That is not a problem. They could randomize the treatment, which means that they could really tell, they could exclude all other confounders, and they could really equal out the groups and make them comparable. And they could even potentially blind, well, the patients would generally be severely ill, so they might be blinded already, but they could blind the practitioners so the practitioners couldn't create a selection bias. Now, if we look here in the corner, here's a nice example of exactly that randomized control trial. It was published in JAMA 2004. It was performed, I think, in the Canadian setting, if memory serves me correct. And the investigators did exactly that. They used a double-blind randomized control trial of TBI patients who were comatose and hypertensive, and they gave them either saline or standard treatment, or hypertonic saline with standard treatment, or only standard treatment without hypertonic saline, and essentially evaluated the outcomes. So this could be a really useful type of study design for this type of problem. All right, so let's go to another problem. Okay, so in this setting, the problem is that severely injured trauma patients have a high mortality despite what is considered a good emergency care system. So the investigators want to study the impact of pre-hospital care on patient survival. Now that seems like quite a difficult study to do, and it might be. They're particularly concerned about the impact of out-of-hospital time because they have a lot of ALS practitioners, and they've noticed that ALS practitioners tend to stay on scene a lot, and they perform a lot of procedures, and they're worried in trauma patients, well, if the patient's not getting to hospital, is that not potentially harmful? So they could use a case control type design. It would be perfectly suited because they could identify the cases of patients who had negative outcomes, such as those who die. They can look at multiple exposures at the same time, which would be really convenient. And they could easily identify cases, but finding control in this case might be a little bit difficult, but not impossible. We look in the corner here again. I included an example published in 1993, so it's a little bit old, of exactly this type of study, where they actually looked at the impact of on-site care, pre-hospital time, and level of in-hospital care, so where the patient was taken to in the actual outcome of severely injured patient. In this study, they refer to it as a case reference study, which is another term for case control study, because essentially they could now test the association between the outcome and what happened on the scene, as opposed to what happened in the hospital, where the patient went to, and who the patient was treated by. For example, here they specifically noted advanced life support. this is a nice, interesting example, and this might be something very interesting to repeat in South Africa and see what our impact of out-of-hospital time actually is. Right, so another problem that we can look at is some smaller descriptive studies done by some EMS researchers have shown that poor ventilation of traumatic brain injury patients in the pre-hospital setting may be associated to poor neurological outcomes. There's some pilot studies have shown this, and investigators really want to know more. But the problem is that we can't test this prospectively by assigning patients to receive poor ventilation. That would be unethical. So because the exposure is harmful, we can't really do an RCT. So in this case, what the investigators could use is a prospective cohort study and say that problems with the ventilation or poor ventilation that occurred could be an exposure that could be studied. So, for example, in this case, we could not assign that kind of exposure, but they do happen, and we can study what does happen. So we could, for example, look in this case at the risk increase and the risk of poor outcomes as documented against this type of exposure. So here's an example of a study like this, where they looked at the impact of pre-hospital ventilation and the nature and how the ventilation was delivered on the outcome of severe traumatic brain injury. And this is also published in 2007, and here they used a prospective cohort study where they looked over a 14-month period at all the patients with head injuries who had received advanced airway management, and looked at the ETCO2 values and therefore derived how well or poorly they were ventilated in terms of what would be considered good parameters for ventilation in these types of patients. Okay. All right, so if we now go to the big city and we start looking at the urban EMS setting, one of the urban EMS providers is a bit concerned about the exposure of their staff to violence, interpersonal violence at sea. And they essentially want to know, well, how often does this happen and to what extent? In this case, they could use a descriptive survey. It might be a useful, easy, and quick way to just document and quantify how often these things occur. They could look at the frequency and the nature of the exposure, and they could assess the nature and strength or the problem. But the problem here is that they could not assess, my apologies, the nature or strength of the relationship here. They could merely just document what happens. So they can't say, well, what is this associated to? Is it associated to Friday night or alcohol abuse and so forth? They can only document that it does occur and that these issues might be present. So here's an example of a study like this, published in 1998. Once again in the American setting, where they essentially just surveyed emergency care providers and looked at how often this had occurred and how many of them reported these sorts of incidences. Okay, so now, coming to our last problem for the evening. And this is something that's particularly topical, I think, for South African EMS at the moment. EMS regulators are in the process of developing evidence-based guidelines and new protocols for emergency care. However, many of the smaller studies, particularly in our environment, because there isn't a large amount of clinical research, are inconclusive, and they don't really provide good evidence for including or excluding practices. So in this case, what investigators could use to help them write these guidelines is to do and produce actual systematic reviews. So if it's well-designed, if they can find well-designed studies, even from elsewhere, that have similar types of patients that were performed using similar methods and had similar outcomes, they can really generate high-quality outputs and high-quality results in terms of whether or not those studies, or in terms of whether or not the treatments that were being studied can be useful and work. So the point estimates, like I mentioned earlier, can be stronger, and we can have new evidence that improves our sustainability as well as improves our clinical practice, which essentially can guide us in terms of whether or not certain practices work. So here's a nice example of a recent systematic review. This is one part of the publication. This one was on airway control techniques in the pre-hospital setting, looking at meta-analysis and a systematic review of orotracheal and nasotracheal intubation, particularly looking at which ones were more successful and what adverse events and what the adverse event rate was that occurred as a nice example. All right. So just in conclusion, I think what's an important takeaway message is that although some of these things do seem complex with some training and obviously good guidance, support and supervision, performing good quality pre-hospital research is most definitely not impossible. Even RCTs, they are possible. I think we just need a team of people in South African EMS who are committed to finding answers to some of the questions that we have. When, however, one conducts research, in any research really, one needs to be very mindful of the design and its limitations and how good it is at finding the truth. Because one of the big problems in research in general is that people tend to easily overstate their findings. And this is something that we really need to guard against. And then just in closing, I think it's very important in terms of where we are at the moment as a profession, that as we in this process of professionalizing, we need to start owning our own body of clinical knowledge. We really need to start producing our own clinical knowledge by conducting research if we are to really improve our practice and start standing autonomously on our own 2 feet and not merely just borrowing from other health disciplines. This is a particularly important, I think, point because if we don't produce our own research, we most definitely stand a chance of becoming obsolete at some point, as we won't have the evidence to back up our care that we want to give patients on the road. Okay, so just in closing then, just want to acknowledge once again Michael and Willem giving me the opportunity, and I hope you enjoyed the session. And just thank Michael for some of his input. He helped to design some of the slides. So just like to thank him for that. And then it's just in closing some of the references that I used. If there's any questions or any specific references or anything that you'd like to know more about, as Michael mentioned earlier, you can definitely email us, and I hope we can respond to you and answer your questions. So I'll hand over back to Michael now, so that you can close the session. Good night.
Thank you, Ben, for a great presentation. For our viewers and our listeners, if you would like to receive your CPD certificate, which is worth 3 CPDs, please log on to the ECSSA website and complete the online questionnaire. Click Submit and you'll be able to receive your PDF via email. That's all from our side. Please remember that our next CPD Hangout will be on the 1st of September 2014.